Hello, my name's Will English. I'm one of the consultants at Royal Cornwall Hospital Critical Care Unit, and welcome to today's tutorial on multiple organ dysfunction syndrome. So what we want to cover today is we want to discuss what multiple organ failure is, what causes it, how we recognise it, and how we treat it. And what I'd also like to get on to talk about is just a little bit about the Surviving Sepsis campaign guidelines, and that's something that you may well want to look at in your own time. I think perhaps the first key concept to be clear on today is that patients who develop multiple organ failure, there's often a number of opportunities in which we can intervene to prevent further deterioration. And there's been a lot of emphasis on the importance of adequate monitoring of physiological parameters and then an appropriate response depending on the derangement of a patient's physiology. And that's something that we'll expand on during the course of today's talk. So a lot of people think that, perhaps preventing something as catastrophic as multiple organ failure is going to be incredibly difficult. But I think that that's not the case, and it's not something that only clever people understand. And actually, the prevention of patients developing multiple organ failure really relates to just timely and appropriate medical practice. Whilst there clearly are a subset of patients who perhaps might have such devastating injuries or infections that they're destined to develop multiple organ failure, that isn't true for every patient who develops it. So first of all, a definition of what multiple organ dysfunction syndrome means. So it's referred to as an internationally recognised term, and what it does is it describes the loss of physiological reserve and progressive organ injury through to actual organ failure associated with critical illness. In contrast to chronic organ failures, of which many patients out in the community and in hospital might be suffering from, multiple organ failure is an acute phenomenon. It describes a molecular phenomenon which leads to a cellular phenomenon and then ultimately leads to organ system failures, and unfortunately it's been shown to be fatal in over 50% of cases. Another absolutely key concept is that it's actually much easier to prevent patients developing multiple organ failure than it is to reverse the process once they have established multiple organ failure. And so for that reason, early recognition is the absolute key. Other people have described it as a domino effect of a series of different occurrences happening which ultimately lead up to the patient developing multiple organ failure. And so this cartoon really is just to depict that, and that perhaps this is the position that you and I find ourselves in when we're asked to review a patient who is in established multiple organ failure. And what we actually need to do is we need to build in fire breaks in this system of dominoes, whereby there's opportunities to intervene and also to identify patients who are actually getting more and more sick. Regarding the pathophysiology of multiple organ failure, there are two factors that we need to consider. We need to consider that there's the variety of different pathophysiological triggers, and then we need to consider the host response. And I think this is a time where sometimes people start to potentially switch off, that we're talking about some complicated immunology. But I think if you can bear with me, you'll perhaps appreciate that this is something that is of some importance. So there are a variety of different pathophysiological triggers that can cause multiple organ failure, and these are common occurrences amongst the patients that we see in hospital. We see patients with sepsis, we see patients with hypoxia, with trauma, or with devastating inflammatory conditions such as acute pancreatitis. And all of these may cause a patient to develop multiple organ failure. So this is just a clinical example of a patient that I was asked to see who certainly did have multiple organ failure, and the cause of that was the fact that they had complete heart block with a totally inadequate ventricular response. So this patient had an effective pulse rate of 12 beats per minute, and I think the other benefit of this case is it shows just how, in order to effectively manage patients with multiple organ failure, we need to adopt a team approach, in that we need to adopt a cardiologist to commence pacing for this patient once we've realised that actually administration of isoprenaline doesn't work. The patient also needed to be given renal replacement therapy. And so again, you can see that the complicated care of a patient such as this is going to involve a large number of health professionals. I have referred already to some of the immunology involved in multiple organ dysfunction, and I think this is important to understand briefly about this. So we'll start off with a physiological insult, which is the triggering event. That can cause a mediator release from inflammatory cells of pro-inflammatory cytokines such as interleukins 1 and 6 and tumour necrosis factor. In turn, this creates a cascade of different events which ultimately ends up with cell and tissue damage and can cause organ failure and sadly can cause patient death. So the inflammatory cascade itself, its intention is to kill invaders and to preserve the self, and it's normally balanced by a counter-regulatory anti-inflammatory system. What we find is that tissue damage and organ dysfunction result when the pro-inflammatory processes predominate and overwhelm these counter-regulatory processes. I think an exciting opportunity for research and for real improvements in patient outcomes is the influence of genetic factors on the inflammatory cascade, and I'm sure this is something that's going to become of increasing importance in the future years. So what organs get affected by multiple organ failure? Well, the clue's really in the name, in that really all of them can get affected. The gut has been described as the engine in multiple organ failure, and what this refers to is that if you've got a patient who's got poor gut perfusion, the normal mucosal barriers can get broken down and you can get translocation of bacteria from the gut lumen into the circulation. The heart and circulation are obviously intrinsically involved. People can develop lung pathology as a result of infection elsewhere in their body. So patients with abdominal infection might develop lung problems. Kidney failure is quite common, liver impairment, derangements of conscious level, and then also you can get skin involvement, and an example of that would be meningococcal disease. So for the remainder of the talk, what I'd like to talk is just to go through a clinical example. So you're the foundation doctor and you're asked to see a patient, and this patient's a 74-year-old man. He's had a laparoscopic anterior section quite a number of days previously, and in general you've been seeing him on a day-to-day basis, and he's been making slow recovery. He's perhaps had an ileus, developed some vomiting, and has had poor nutrition. But today the nursing staff have phoned you specifically to ask you to come and see him because they're concerned that he has a high news score and that he's pyrexial and confused. So this is a situation that you're going to find yourselves in within a year or so when you're qualified. So you need to think about what you're going to do before this situation arises. And so these two sheets of paper should not be new to you. So on the left-hand side of the screen, there's a national early warning score. And on the right-hand side is actually a guide as to, dependent on what early warning score your patient has, what sort of response you should be looking to get. So this is basically an aggregated scoring system for physiological derangement. So the sicker you are, or the lower your blood pressure, the more points you score, or the higher your respiratory rate, the more points you score. And patients who score higher points need to have a more rapid response by a correspondingly more senior team of clinicians. So maybe what you do is you get this phone call, the news score is very high, and you actually speak to the person and ask them to call for some extra help. Tell them that you're on your way immediately, but perhaps that you'd ask them to call your senior. On arrival, you need to perform a rapid structured assessment of the adequacy of the patient's airway, breathing and circulation, together obviously with a disability and exposure assessment. You need to obtain appropriate IV access, to obtain appropriate blood specimens, possibly including blood cultures, another septic screen if the patient's thought to be infectious, and then a whole host of other investigations. And we've already seen the ECG was an important investigation in a patient with a pulse rate of 12 beats per minute. At this stage, you need to reconsider the need for calling for help if that hasn't been done earlier, or if the help hasn't arrived, or if the patient's deteriorating. And then something that I think that we're better at assessing patients than actually perhaps documenting what our management plan is. And what we need to then do is to formulate, enact and document an appropriate management plan. So going back to this patient, your assessment is that the patient's got a patent airway. They've clearly got some respiratory pathology with they're very hypoxic and got evidence of respiratory distress. It appears that they're in atrial fibrillation, although you're waiting for an ECG. They're very hypotensive and they've got very, very poor peripheral perfusion. They're mildly confused. They've got clear evidence of a pyrexia, and so that raising the possibility of them having a significant infection. As part of your other assessment, they've got tender abdomen with guarding, and there's evidence that they've become anuric over the past 24 hours. So what do you need to do? And I think we've all been in this situation where we've been faced by acutely unwell patients, and it can actually be frankly overwhelming at times. And this is where actually your training and sticking to a structured approach helps. You need to perform a rapid assessment of the adequacy of the patient's airway, breathing and circulation. You need to address these problems as they arise. And it may be obviously that you're not going to be able to, on your own, sort out a patient with a significant airway problem, and so you're going to need to call for help. That can come from your team, from the outreach team, possibly from the critical care department. At that stage, you need to consider the need for specific formal organ support, and also again it's really important to remember that definitive management of specific conditions such as the appropriate antimicrobials or source control and sepsis are extremely important, and that actually we need to perform those measures as well as supporting our patients in the hope they're going to get better. So I did mention that I was going to talk just briefly about the Surviving Sepsis campaign. This is now in its third iteration, having been originally conceived in 2002, and this describes a number of different interventions that need to be done in order to help patients with suspected infection and problems relating to that. I think this is something that I'd like to refer you to for your further learning from this talk, and I can't really recommend this highly enough, and it won't take you much time to go through it, but it will help. Perhaps if you see a patient on the ward, perhaps what you should be doing is then contrasting their care to the care suggested by the Surviving Sepsis campaign. So to summarise, what we've got in multiple organ dysfunction syndrome and within the pathophysiology is that we've got multiple opportunities in this cascade of events to intervene and to improve the outcomes of our patients. So to summarise, multiple organ dysfunction syndrome is unfortunately fatal in around 50% of cases. But what we know is that early recognition and early intervention improves survival. I think what we also need to realise is that actually our assessment and management needs to be systematic and logical, and it needs to follow an ABC approach. And we need to not be overwhelmed by meeting a patient who's critically unwell. My last plea is regarding attention to detail, and I think that it's clear to see that in some of these patients who are extremely unwell that there might be interest as to what's actually happened to them whilst during the course of their treatment. And so documentation is very important, as is communication with other teams. So thank you very much for listening. I hope it's been informative, and as I said, I'd like to refer you again back to the Surviving Sepsis campaigns. The most recent guidelines were made in 2012, and just have a think again about whether you should be contrasting the care of the patients that you've seen with the care suggested by that campaign. Thank you very much.